So we left off at this, we talked about subcorneal and intraepidermal blistering diseases last time. So we're going to quickly finish up the subepidermal blistering diseases, and then we'll go into our study sets. So subepidermal blisters, when you look at them, you need to classify them as cell poor and cell rich. So when thinking about something being cell rich or cell poor, you're looking for inflammation within the blister cavity and the base of the blister. And blood doesn't count. So for example, in this particular case, this is a pretty clean cell poor subepidermal blister. Now, common to all the cell poor subepidermal blistering diseases will be some type of festooning or caterpillar bodies. When you see a cell poor subepidermal blister, the way I think about it is I classify them broadly in my head as, is this going to be DIF positive or is this going to be DIF negative? So the DIF positive entities would be epidermolysis bullosa acquisita, porphyria, and pseudoporphyria. And the DIF negative diseases would be the inherited epidermolysis bullosa group of diseases such as EB simplex, hemidesmosomal, dystrophic junctional EB. The second category would be bullous diabeticorum, and third would be like a drug-induced process, especially NSAIDs, non-steroidal anti-inflammatory agents, can produce cell-poor subepidermal blisters, which are DIF negative. So those are the two broad categories I think about, because honestly, when you look at a cell-poor subepidermal blister, just by looking at it, it's difficult to determine what are you dealing with. So there has to be some kind of a second-order question which will point you towards that. So like this is a cell poor subepidermal blister. So if you know, this is the kind of thinking I want you to have in your mind as being DI positive, DI negative, and then what diseases fall under each category. Another common phenomenon that we see with subepidermal blisters is scarring. So when you see a subepidermal blister with scar, like in this particular scenario, again, the scar will tend to make the blister look busy, but the inflammation is because of the scar and not because of the blister. And again, by looking at it is in the blister cavity. The blister cavity looks a little like it clean here. There's a little bit of fibrin, but other than that, it looks pretty clean, and there is a scar down here. Let me show you, I think, another example where we not only have a scar, and I think there is a milia formation as well. So let's see another example. I think it's probably this one. No, not this. Yes. So here you see a subepidermal blister, which clearly has a scar and it has this milia formation. So when you see a cell poor subepidermal blister with scar plus minus milia formation, the things that you think about are EBA, porphyria, and pseudoporphyria. And you think about dystrophic epidermolysis bullosa as well as cicatricial bullous pemphigoid. So those are the diseases that you think about. So EBA, porphyria, pseudoporphyria, dystrophic EB, and cicatricial BP. Now, among these, dystrophic EB is going to have a negative DIF, and all the others are going to have a positive DIF. So that's the other way of thinking about it. So I want the differentials in your mind to be clear. Let's talk about simple questions that tend to be asked with related to, you know, the cell poor subepidermal blisters. So if you see a subepidermal blister, again, the hemorrhage doesn't count, and you know, you are seeing a blister here. This is all filled with blood, but other than that, it is basically very cell poor. And you see the nice, there is the festooning. The choices are EB or porphyria or pseudoporphyria. You look for perivascular hyalinization of the vessels in the blister base. So you can see here, these are pretty thick walls adjacent and within the blister cavity, base of the blister. So these findings are consistent with porphyria or pseudoporphyria. So typically, you can see this is lots of blood. There is solar elastosis, but then you can see a nice cell poor subepidermal blister, and you can see that the vessels in the base of the blister, they are very hyalinized. So this is an indication that this is porphyria or pseudoporphyria. This is where your deposition of the immunoreactants will occur on DIF, producing what is known as the donut vessels. So that can be something which can be used for porphyria, pseudoporphyria, but other than that, from a distinction of that from EBA, but both entities on histology will show overlapping features. Obviously, the DIF of these entities is very different. DIF of EB is similar to BP, and the DIF of porphyria and pseudoporphyria will show perivascular deposition of immunoreactants producing those donut vessels. So EBA and BP both show linear deposition of IgG and C3 along the basement membrane. And to distinguish between the two, you need to do either a salt split skin analysis, which is again done as an extension of your DIF. So in a salt split skin analysis, if you see deposition of the immunoreactants in the roof of the blister, then that would be BP, and if it is in the floor of the blister, that would be EBA. It's opposite if you do an immunostain. So in the lab, we can do an immunostain for type 7 collagen, and that will show reverse staining pattern. So if it is staining in the base of the blister, that is BP, and the roof of the blister is EBA. So that's with the immunostain as compared to the salt split skin analysis. Okay, now let's go on to your cell-rich subepidermal blister. So when you see a cell-rich subepidermal blister, and again, all the cell-rich subepidermal blisters will show within the blister cavity this kind of a pink fibrinous degenerative debris. And accompanying that is going to be the inflammatory cell. So you can see that there are a lot of eosinophils in the blister cavity here, and so also in the base of the blister. So the cell-rich subepidermal blister, which has a lot of eos, you think about BP, bullous pemphigoid, or any of its variants. So cicatricial pemphigoid can do that, even though it can be cell poor, it can produce this. Pemphigoid nodularis can do that. A prodromal BP, even though it has to have the subepidermal vesiculation, and pemphigoid gestationis, which is BP in pregnancy. So anything which has the has a cell-rich subepidermal blister with eos, you will think about bullous pemphigoid and the related group of diseases. Now, one of the things which I want you guys to pay attention to is, and not get confused in that in a long-standing subepidermal blister, the roof of the blister may become necrotic. And if you are not paying attention to the blister cavity, you may think that this is your lacy epidermal sign, your interface-mediated epidermal necrosis, because this looks necrotic and you have an intact stratum corneum above it. This is not TEN or interface-mediated process like bullous EM or EM major. So you have to make sure that you're looking in the blister cavity. And the other signs that this is a long-standing blister is that the blister base is going to be partially reepithelizing. So you can see here that the blister base is starting to reepithelize. So this kind of a pink material within the blister cavity with EO is very classic for BP. So make sure that you're not missing that. You're not overthinking the cause of the blister. Okay, so the next entity I'm going to talk about is prodromal BP. We have talked about this particular entity, but since we are dealing with blistering disease, I just want to go through it again. So in prodromal BP, the things that makes you think about something being, an early stage of BP is when you get disproportionate eosinophils. They're not going deep down, and it's not accompanied by a lot of spongiosis. So when you see especially a band of eosinophils in a lichenoid distribution, in the superficial dermis, and the eos are not going very deep down. The deep actually looks pretty clean. That's something which an arthropod will not do. And also contact dermatitis, if it has this many degree of eos, it will show you much more obvious spongiosis. Another feature which always makes you think about prodromal BP is when you see eosinophilic exocytosis. So when you see eosinophils which are pouring out into the epidermis and especially lining up along the D junction, as you can see in here, that's another very good clue that you may be dealing with BP. So typically you do not get eosinophils pouring out into the epidermis or lining up along the DEJ. So when you see that, as you're seeing in this, it should always make you worry about BP. So those are some of the things about recognizing prodromal or early phases of BP. Okay, now coming to your next entity, how about if you see a cell-rich subepidermal blister with neutrophils? The cell-rich subepidermal blister with neutrophils, the things that you think about is dermatitis herpetiformis, linear IgA disease, chronic bullous dermatitis of childhood or linear IgA disease in kids, and bullous lupus. In real life, there is a lot of overlap between a cell-poor, cell-rich with EOs and cell-rich with neutrophils, all of those blistering diseases. But for your board purposes, they're looking for some clear-cut definable features on your histology. So typically a blister of DH is going to be excoriated. You know, it's a pretty pruritic eruption. And so you see often ulcer secondary to excoriation. And you may miss the blister completely. The clue that, you want to go through all the levels. So make sure that if it is you're dealing with DH, you want to look at all the levels and look for the section which will show this nice collection of neutrophils at the tip of the dermal papilla. This is classic for DH. Other thing you want to do is make sure that you're looking at the vessels in the dermis, because pustular leukocytoclastic vasculitis, or LCV, can produce you this kind of a collection of neutrophils at tips of dermal papilla, but you will see nice vascular destruction of leukocytoclastic vasculitis. So please remember, pustular LCV can look like DH. So if you're not paying attention to the vessels, you are going to miss it. But this is dermatitis herpetiformis, classic location of the neutrophils at the tips of the dermal papilla. And this is where the IgA deposition will also occur at the tips of the dermal papillae on DIF. Okay, in contrast to this, a linear IgA disease is going to be more of a linear split. So in linear IgA disease on low power, it looks like BP. You will see again a subepidermal split with fibrinous degenerative debris in the blister cavity. And you will see a lot of neutrophils as compared to eos. Now, it's not that this entity will not contain any eosinophils. Similar, like BP will not contain neutrophils. It's nothing like that. They will have both cells, but it's a predominant cell type that you are looking at. So in this particular field entirely, and make sure that you're not interpreting the red blood cells as eos, because the distinction requires recognition of the inflammatory cells, so you have to be very certain. So you can see all of these are neutrophils. It's in a linear fashion. This goes very well for linear IgA disease, or chronic bullous dermatitis of childhood, which is linear IgA disease in kids, or even bullous lupus. So they'll have to give you a second order question to be able to distinguish bullous lupus from linear IgA disease. This is linear IgA disease, which should be the same as bullous lupus. And another thing, bullous lupus has got nothing to do with the histologic findings of classic lupus. So classic lupus is the one which presents with chronic interface changes. We have talked repeatedly, a thick basement membrane, necrotics, epidermal atrophy, and all those features. However, bullous lupus is an acute blistering eruption which occurs often with patients with SLE, and it can be the first presenting manifestation of the disease process. So it shows acute features. It will not show any interface. It will not show any thickening of basement membrane, not show any mucin. It will look exactly like linear IgA disease, a cell-rich subepidermal blister with neutrophils. The DIF findings will be pretty classic for lupus. You will see post-granular deposition of multiple immunolatins along the DEJ and in the epidermis. That is fine. But as far as the histology is concerned, it has got nothing to do with classic lupus. So just keep that in mind. And then lastly, don't forget entities like lichen planus, which can also produce you a subepidermal blister from the Max Joseph space. So in lichen planus, you have the nice subepidermal vesiculation because of the liquefacted degeneration of the basal layer, which is called your Max Joseph space. But the clue for this will be where you don't see a blister, you will see the nice lacunar inflammation with the hypergranulosis and the cytoid bodies. Again, a bullous LP is not the same as lichen planus pemphigoides. Lichen planus pemphigoides is a true overlapping entity between patients have lesions of LP and they have bullous pemphigoid. This is just secondary subepidermal vesiculation in lichen planus. So it's not a true immunoblistering disease, whereas lichen planus pemphigoides is. Okay, so with that, that was my teaching you guys of blistering diseases. So I think we can jump into the study set and let's start. Anand. Yes.
Question, sorry, what did you say the last slide was?
Bullous LP.
Okay, the one you were just showing.
I was trying to say that you should not confuse bullous LP from lichen planus pemphigoides. Bullous LP is not an immunoblistering disease, but lichen planus pemphigoides is. So the patients have simultaneous lesions of LP and BP. So the DIF in lichen planus pemphigoides will be that of BP, which would be linear deposition of IgG and C3 along the basement membrane, whereas in bullous lichen planus, it will be of lichen planus. And in lichen planus, you get just cytoid body staining with the immunoreactants.
Okay, thank you.
Okay, yeah, welcome. So now let's jump into our blistering study set, and this is the first one, and would love a discussion from you guys. So let's tackle the first slide. So what do you guys think about it? Anybody can attempt it, and I'm going to be there to walk you through it.
This is an intraepidermal blister.
Okay. Mm-hmm. So what do you think about what does this remind you of?
Like the brown stuff.
The whole, like this whole, like what is happening here? So you have an intact stratum corneum, right?
Oh yeah, yeah.
And right beneath it is what?
An intraepidermal split.
Yes, with the dead epidermis, right?
Mm-hmm.
So a dead epidermis juxtaposed beneath a intact stratum corneum. What is the sign called?
The lace sign.
Yep, the lace sign. So what does that indicate?
Interface mediated necrosis.
Yep, which is what you see in
SJS or EM or fixed drug.
exactly. So any of them could be the right answers, right? So bullous EM, bullous fixed drug, or EM major, Stevens-Johnson, TEN. So either they give you like a clue for it, or if they are not giving you any clue, this would be a little challenging. But if they do not give you any clue and they ask you to pick it up, then you see that there is a significant amount of pigment dropout. And see these EOs?
Mm-hmm. So this would be fixed drug.
Bullous fixed drug. Yes. But the key from this is, I don't care what you pick up, bullous EM, bullous fixed drug, EM major, Stevens-Johnson, that's fine. You'll be able to pick it up finally. I want you to recognize the reaction pattern. And this is the lace epidermal sign. So this is an intraepidermal blister with interface mediated epidermal necrosis, where you see an intact stratum corneum with a dead epidermis beneath it. And the blister cavity is containing all this dead epidermis. There's no fluid as what you would see in bullous pemphigoid. Often the clue also, you can try to see in the adjacent intact epidermis. Unfortunately here, this is not showing anything much. So quite often if I get confused, I will look in the adjacent epidermis. So that may tell you the cause. So you may see dead cells interface change in there. But this by itself is pretty pathognomic for interface mediated epidermal necrosis.
I think the confusing part for me was the epidermis, like, doesn't really look intact to me. Like, it looks dead.
The dermis?
Or the epidermis, like you said, intact epidermis.
No, I didn't say intact epidermis. I said when they were trying to biopsy this blister and they got a portion of adjacent normal skin.
Okay.
Here, which is how you should always biopsy it. When you're biopsying a blister for histology, you should include the edge of the blister with adjacent normal skin. Do not just punch the blister itself.
Gotcha. Okay.
And the reason is because sometimes the adjacent skin may tell you the cause of the blister, because if the blister is long-standing enough, it may not be reproducible of the cause of what is causing the blister. The story begins at the junction.
Mm-hmm.
This is what I was saying. But in this particular scenario, this is not very helpful, but the blister by itself is very helpful because it's pathognomic.
Gotcha. Okay, I see what you mean. Thank you.
Yes, yeah. Okay, let's go to the next one, which is your slide number 2. Okay, so this should be like instantly recognizable. What is that?
Psoriasis.
Yep, this is guttate psoriasis. This slide is like the best slide of guttate psoriasis I've ever seen. Like, it's like all the pathognomic features. You see the stuck mound and the dirty mound with loss of granular cell layer beneath it, and you see the nice elevated mounds with neutrophils in it. So if you ever have to learn what a stuck and a dirty mound means, this is the slide to go for. Like, it's got all the beautiful features of guttate psoriasis. You can see the nice elevated mound with neutrophils and the stuck mounds. The stuck mounds are so beautiful. So anybody who did not get this, this is like the slide I want you to go back and take pictures and use it for your memory, because this is beautiful for guttate psoriasis. Okay, let's go to the next one. Like the first slide, the dead epidermis was beautiful for the lace epidermal sign. So that's how it looks like in an interface mediated process. Okay, this is the third slide. This is also very pathognomic for this particular slide. What is this?
It's lichen planus.
Yeah. And do you see all the recognizable features?
Yeah, I'm seeing the wedge-shaped hypergranulosis there, the lichenoid infiltrate.
Yep. So this has also got like the most classic features of LP, the beautiful irregular sorted acanthosis. You can see the cytoid bodies even from here. And you see the beautiful wedge-shaped hypergranulosis and the hyperkeratosis. This is a lesion of LP, right? We have next one, which is a slide number 4. This is also so classic for this entity. And what is the diagnosis here? Come on, guys, you know what it is.
This is BP.
Yeah, this is also perfect for BP, right? Can you describe to me what you're seeing?
There's a subepidermal split and then a ton of EOs.
Yeah, and you see all this fibrinous degenerated stuff in the blister cavity.
Yeah.
So that's classic for BP. Good job. So this is beautiful for BP. Okay.
Why does the fibrinous stuff matter?
I don't know why it happens, but you always see it in BP. And the reason I always use it, I always pay attention to it is, again, in a long-standing blister. In a long-standing blister, sometimes the roof will become necrotic and the base will start reepithelializing. So then you are like arguing with yourself, is this a subepidermal or an intraepidermal split? But then when I see this fluid in the blister cavity, like that's the example that I had showed you when I was teaching you guys, that is like, no, this is a subepidermal blister. So it's nice to see these features which people don't talk about a lot, because these will help you in recognizing it. So when I look at it at low power, like I instantly know it's BP. Actually, my eye is not even going to the level of the split. It's actually going to this fluid within the blister cavity. Okay.
Got it. Thank you.
Okay. You have the next one, which is a slide number 5. Okay, this is a little difficult one, and I'll help you guys through it. But I want somebody to take the lead and walk me through it as to what features you are seeing, so I can see it with your eyes. Because to me, it's very obvious, but I want to, so that's why I want an input from you also, that I can help you.
There's another subepidermal split.
Where do you see the subepidermal split?
Right in the smack dab of the center.
This
right
one?
there. Yeah.
Yes. So the first learning experience from this is, do not ignore your eyes. If you think that it is a split, it is a split. And what is the other prominent feature in this?
Neutrophils.
So neutrophils, where do you see the neutrophils?
I actually am not sure if those are newts or lymphs in the dermis.
Okay, we'll go on high power. They're limbs.
Yeah.
So, but before you go on high power, I want you to see another particular thing. Is this normal dermis?
No, it looks kind of sclerotic.
It looks like a sclerotic, exactly. And you see that there is, you see all the fibroblasts in here?
Yeah.
They are arranged parallel to the epidermis. So that's this, and you see all the vessels, how they are like sticking up perpendicular to the epidermis. So this is a feature of a scar. So there is a scar in the background and there is a split. So whatever inflammation that you're seeing in the dermis is because of the scar, but the blister by itself is pure cell poor.
Mhm.
Go back into it. This thing is not working. Okay, so yeah, you see here that there is a cell poor subepidermal blister and there's a scar. So you discount the inflammation because of the scar, you're seeing a subepidermal blister which is cell poor. So remember from my talk I just gave you, when you see a cell poor subepidermal blister with scar, what are the diseases you think about?
PCT, pseudoporphyria, and EBA.
And dystrophic EB,
Sure.
forget that, and cicatricial BP.
Mhm.
Okay, so they either give you one of those answers or they tell you a second hint. So what if I tell you that the DIF on this patient was negative?
You would think more of like dystrophic EB.
Yeah. So this is dystrophic EB. This is the patients with dystrophic EB often present with like later onset blisters in their life. So this was like a 16-year-old who had recurrent blistering eruption on his leg. This is in a patient with dystrophic BP, or dystrophic EB.
Can you just repeat that differential?
Yes, so if you see a cell poor subepidermal blister on scar, and the other thing which can happen is milia formation also over here. First of all, it's the inflammation in the blister cavity. Anything that accounts in the scar is because of the scar, the inflammation. So this is a cell poor with scar and a subepidermal blister with scar. And so you think about entities like EBA, porphyria, pseudoporphyria, cicatricial BP, and dystrophic epidermolysis bullosa.
Perfect, thanks.
Okay. Let's go to our next one, which is just slide number 6. Okay. So what do you think is happening here?
Seeing like dermal edema,
Yep.
and I think those are mostly lymphocytes.
Yep, they're lymphocytes. And then what else do you see?
Some eosinophils too. Maybe this
Yep.
is like urticaria.
Yes. So this, if they give you a single shot of this in your boards, this is defining for urticaria. It's as classic as it can get, because you see all the edema and you see the eosinophils, they're like running away from the vessels. So that is a hypersensitivity dermatitis, and overall the epidermis is completely unaffected. So this is beautiful for urticaria. You can also see sometimes, not sometimes, you will see neutrophils as well. And sometimes eos and neutrophils can both be very predominant, and that's normal for urticaria. Okay, good. We have the 7th. Okay. What do you think about this?
This looks psoriasiform.
Yeah. Beautiful psoriasiform, yeah. You can see the bulbous VT ridges, you see the suprapapillary thinning, you see the dilated vessels. So what is that?
Is it just psoriasis?
It's psoriasis. Now, this slide, as compared to the next slide I want to show you, is these are the lesions of psoriasis which more often get biopsied by you guys. Why? Because you can see that this also has spongiosis. So you're seeing the pallor in the epidermis, it has a good degree of spongiosis. And you see there is crust overlying it. There is like true spongiotic crust overlying it. So you can see how clinically this lesion would be like, is this psoriasis or eczema? These are the kind of biopsies of psoriasis that we get, where sometimes a distinction between psoriasis and eczema can be challenging. But then you see at the other features, the suprapapillary thinning, the dilated vessels, which is like the most first most important clue. And then this for, is not as challenging because you can see the nice bulbous VT ridges, the superpapillary, the fused VT ridges, the bulbous pattern, and the nice loss of granular cell layer. So this is what is psoriasis with spongiosis. The next particular slide is what? What is this? What are all these?
Neutrophils.
Yeah.
Is this pustular psoriasis?
Yeah, this is classic psoriasis. This is the one which will have the nice silver scale of psoriasis, and that's what is forming that. So you can see the beautiful psoriasiform acanthosis again. This has like the perfect loss of granular cell layer, complete hyperparakeratosis with like neutrophils which are actively pouring out into the epidermis. This is your Munro's microabscess right there, which is forming like a micropustule. In pustular psoriasis, the subcorneal intraepidermal neutrophilic pustule, the background epidermis, it may not show the classic well-formed features of psoriasis. This is just classic plaque of psoriasis, which most of the times does not even get biopsied because this looks clinically so much like psoriasis to you guys that you don't even prefer to biopsy it. Another thing which I want you to recognize is follicular plugging. So we talk about follicular plugging for PRP and sebderm, but follicular plugging can also be seen in psoriasis. So if you're seeing a plugged follicle, yes, you think about sebderm and PRP, but just because of that, you're not going to exclude psoriasis. You can definitely see follicular plugging in psoriasis as well. And then the background changes in this is nothing PRP-like because you're seeing loss of granular cell layer and neutrophils in the condyphile layer, which are the two complete opposite features of PRP. Okay? So I want you guys to go back and I want you to look at these slides again because these are all very, very classic slides for these entities. Okay, let's go to the next one, which is your slide 9. Okay. So what do we think about this? Does the epi look normal?
It looks thin.
Yep. Yep. And then what else is happening with it? It's atrophied. What do you think about the DAJ?
Is this like a chronic interface process?
Yeah. It's a chronic interface process where you can see the nice squamatization of the basal layer. So the basal layer of the epidermis is looking a little irregular. It's looking hyperchromatic. It's called squamatization or AK-like. And then you can see the beautiful thickening of the basement membrane. And in this particular scenario, and this can happen in long-standing entities of connective tissue diseases, that it almost looks like a pale papillodermis, but it isn't. It's just an altered the basal layer, kind of like involving the papillodermis. So the clue is again to look at the overlying epidermis and see the atrophy, the squamatization, and you can see here the very thick basement membrane. So this is in a patient with a connective tissue disease, which could be either lupus or dermatomyositis. I believe this was from a long-standing plaque of DLE in this particular patient. Okay,
Wait, did you say PLE?
DLE.
Oh, DLE. Got it. Thanks.
Yeah. Okay, let's go to the next one, which is slide number 10. Okay. Okay, ignore the dot. I don't know what. I forgot to remove the dot before I scan this thing in. But what do you think about this? What is the disease process in here? I think these first few slides are a little bit more in the what we have done before, and then there are a bunch of our blistering disease slides coming up. Okay.
So this looks like acute interface with lots of inflammation and an intact stratum corneum.
Yep.
So EM.
Yeah, so this is beautiful for EM. Again, you can see that there is a very acute process. When you see necrotics at varying levels, not many entities would do that. It would either be EM or fixed drug. So good. The next one is 11th. Okay, this is a nice one. So if I gave you, what's your diagnosis here?
BP.
Describe it. It's a,
Subepidermal split with like EO rich.
is it EO?
Aren't those little baby EOs?
These are not EOs, these are neutrophils.
Okay.
Let me see if I can see. This is a red blood cell. I'm trying to see if I can see an eosinophil in here.
Like right in the center, you see that little baby EO
Right in the where, I'm sorry?
right in the center. Up,
Like
up a little bit next to that. Yep, right there.
This?
Mm-hmm.
That's a red blood cell.
Okay.
So actually all the cells that I'm seeing in this field, maybe that's an EO. But other than that, every other cell in here is a neutrophil.
Can you point to the EO one more time?
Maybe, I'm not even 100% sure. Maybe this is an EO because I can see some granules in here. But the rest, all of them, they are neutrophils. And if you're getting confused with the color, I want you to see the multilobated nature of the nucleus. So let's see if we can see an eosinophil in here. This is an EO. This is an EO. See, it's bilobed with granules. This is a neutrophil. This is a neutrophil. This is a neutrophil. This is a neutrophil. That is an EO.
Thank you.
What about the one to the left and to the bottom of the one you're pointing to?
One to the where? Left.
Left and bottom of the one you, yeah,
Yes.
that one.
That's also an EO.
What about to the right of that one?
This one?
Yeah.
That's a neutrophil. So for me to call something an EO, like I don't think about it a lot, but it instantly signs out because A, either the granules are very prominent, which is what is happening in this, or B, I look at the lobation of the nucleus. So this is like a bilobe. This is a neutrophil. You see how flowery it is?
Mm-hmm.
That's also probably a neutrophil. This is also a neutrophil. So you have to be very sure because you're relying on your entire thing for making that distinction. So this is like 90% neutrophils. This is an EO right here. This is an EO. There is a bunch of blood in here, but most of the cells in here are neutrophils. Okay?
Mm-hmm.
So if you see this subepidermal split, you will call it linear IgA disease or chronic bullous dermatosis or bullous lupus. But in this scenario, what is this? If you just had this.
Dermatitis herpetiformis.
DH, yes. So what I'm trying to tell you is in your board purposes, if you got this complete slide and you're seeing this, this finding trumps over this. So you will pick up DH. But if you just see this, you will call it linear IgA disease or bullous lupus or chronic bullous dermatosis of childhood. Okay. And then if you're calling something DH, please make sure that you're looking at the vessels and there is no vasculitis happening. You get what I'm trying to say?
Yeah.
So this is DH. Okay, let's go to your next one, which is your slide number 12. This should be simple. So what is this? Oh, guys, you can do this. There's clearly a split. What is the level of the split?
Subepidermal.
It's subepidermal. Is it cell rich or cell poor?
Cell poor.
It's pretty cell poor. And you see the nice, this is what is the festooning means, right? So if I told you this is entity is DIF positive, what is the diagnosis you will pick? You look at all these vessels. So what's the diagnosis?
Porphyria.
Porphyria or pseudoporphyria. So porphyria or pseudoporphyria look exactly identical on histology. They have the exactly identical DIF findings. So you need to distinguish them based upon clinical presentation and most importantly, serum and urine porphyrin studies. That will make the distinction between porphyria and pseudoporphyria. Okay, so this is a pathognomic slide for porphyria or pseudoporphyria. Let's go to the next one, which is a slide 13. Okay, this is also pathognomic for this entity. What is this?
This is pemphigus vulgaris.
Yes, can you please describe it?
So it's an intraepidermal split with acantholysis, and then the basal layer is preserved.
Yeah, so you can see the nice tombstoning, but most importantly, what is this?
Involvement of the follicular epithelium.
Yeah. So you can see there are two hair follicles here and they are being massively involved by the acantholytic process. So this is classic for pemphigus vulgaris. You get suprabasal acantholysis with intraepidermal split, the tombstoning, and involvement of the hair follicle. So that's pemphigus vulgaris. Great job. Let's go to the next one, which is slide 14. Okay. This is producing you an illusion. What does this look like? Like if you just had this. Because you can do this. What does this look like?
Is this like also acantholytic or no?
Is it acantholytic?
I mean, there's like all these spaces between the cells. I don't know if I'm just like hallucinating it, but.
Yes, there are spaces between the cells, but that doesn't make sense, right? Why would there be spaces between the cells? What does this look like?
Nitidus, like ball and claw.
Yeah. What did you say?
I'm seeing like a ball within a claw.
Yes. This is a tiny lichenoid papule with the ball and a claw, which looks pink because what have I taught you? What is the inflammatory infiltrate in a ball and claw? What is that entity you're talking about?
Like a nitidus?
Like a nitidus is the most granulomatous entity. So the lichenoid inflammation is actually very granulomatous. That's why you're seeing the pink. This is also like, you see the ball and the claw?
Yeah.
This has produced you a secondary subepidermal blister, almost like a mini max Joseph space. You're actually seeing a giant cell in the lichenoid infiltrate, which is very common in lichen nitidus. So this is lichen nitidus. And you see the tiny lichenoid papule here as well?
Mhm.
If I had not given you this in the blistering diseases, if I had put in this in the lichenoid diseases, you guys would have jumped at lichen nitidus. There is no doubt in my mind. Is everybody seeing those balls and claws pretty well or now? No.
Yeah, I can see it.
Okay, so that's lichen nitidus with secondary subepidermal vesiculation. And remember that a granulomatous infiltrated lichen nitidus is pretty common. It's not uncommon. Okay, slide number 15. This is also very classic for this entity. What's the diagnosis here?
Haley.
Yes, can you describe to me why?
There's an intraepidermal split with acantholysis and a dilapidated brick wall on the right-hand corner.
Yes. So if you just had this, you would be like, okay, could this be pemphigus vulgaris? But you have this, which is your beautiful dilapidated brick wall, which is incomplete acantholysis. So this is very classic for Haley disease. This pattern. Good. Let's go to the next one, which is your slide 16. Okay. What's that? What's the level of split, if there is a split?
Subcorneal.
Subcorneal split. So what is your differential in this?
Bullous impetigo, bullous tinea, pustular psoriasis.
I can tell you there is no fungus in here. And the gram stain is negative. So the PS and gram stains are negative.
So pustular psoriasis.
Okay, it can definitely be pustular psoriasis. I'm not denying that. I'll have to go back into the history to check it out. What else can your multiple choice questions contain? If they somehow exclude, so they tell you, they give you this and they say PS is negative, the gram stain is negative, the DIF in this patient is negative, no significant history of drug exposure.
Sneddon-Wilkinson.
Exactly. This would be Sneddon-Wilkinson disease. But in the I will be able to exclude. This is not, even if I didn't tell you that the PS was negative, you will know. This is not bullous impetigo. Though you may think that these debris are bacteria, they are not. So this is another lesson to learn from this slide, that when neutrophils get broken down, there will be a slide coming up of bullous impetigo. The bacteria clump together. So if you're not seeing them clumping together, those are broken down neutrophils. Those are not bacteria. Okay, this is going to be too much neutrophils and too less acantholysis for something like pemphigus foliaceus. It's definitely not staphylococcal scalded because it's too inflamed. Really, the only things that left behind is pustular psoriasis or Sneddon-Wilkinson disease, and it's not even HF because the dermis looks pretty clean. And over there in HF, you should see drug eosinophils. So pustular psoriasis and Sneddon-Wilkinson are the only two things which I would be thinking about. So they'll have to tell you something which makes you not think about pustular psoriasis. And this would be Sneddon-Wilkinson disease.
So you said they would have to say it's the gram is negative, the DIF is negative, there's no new drugs, and then what else?
So go down your differential. It cannot be tinea. It cannot be of infection, so bullous impetigo. The DIF negative for immunoblistering dermatosis, because you can have pemphigus foliaceus or IgA pemphigus looking like this. and then drugs for AGEP. Yeah, so once you exclude that, this is Netter-Wilkinson disease. Also making sure it's not pustular psoriasis.
Gotcha. Okay, cool. Thank you.
And so don't confuse the debris for bacteria. That's another common thing which I get, which you guys get sometimes confused with. Okay, this is a slide number 17. Okay, so good. What is the level of the split here?
Intraepidermal.
You said intraepidermal?
I think so.
Why do you say intraepidermal?
Mm,
This is the epi.
there's like so much inflammation that I can't tell if there's like inflammatory cells or keratinocytes between like above the DJ.
Okay. So now what do you think?
Now it looks more like just inflammation above the.
Yep.
Yeah, so maybe it's subepidermal with like a ton of newts.
With a ton of newts, exactly, in a linear fashion. So what do you think is your differential in this?
In a linear fashion, like linear IgA.
Yeah.
And
You understand what I mean by linear fashion, right? Like unlike in your DH, you were getting those concentration of neutrophils at the tips of the papilla. This is like more like a linear split, BP-like split, where you're getting neutrophils in the blister cavity.
so then it would be either linear IgA or chronic
Bullous
bullous.
dermatitis of childhood or bullous lupus. This is from a patient with linear IgA. Is everybody clear with that? Okay.
Sorry, bullous
Yes.
lupus, and what was the other one?
It would be linear IgA, bullous lupus, and chronic bullous dermatitis of childhood.
Okay, thank you.
Let's go to the next one, which is linear IgA in kids. That's the one which has the classic, what is that called? Those blisters in a circular fashion. That's called by some sign. What is that sign?
Crown of jewels.
Crown of jewels. Yes, it looks really pretty. Okay, so now this is the slide number 18. So what is this biopsy being done for?
Alopecia.
Alopecia, because these are round horizontal sections. And what do you think?
There's like a dense inflammation, and I thought I saw some like perifollicular, like fibrosis, or yeah, concentric fibrosis.
Where are you seeing perifollicular concentric fibrosis?
You know, now I don't see it, but I have it written down in my notes that that's what I saw at some point.
Yes. Yes. So perifollicular concentric fibrosis, if you're seeing that, would be LPP-like.
Okay.
And inflammation would be lupus-like.
Okay, that makes
Okay.
sense. Yeah.
So this is a scarring alopecia from lupus, not LPP.
Okay.
Okay. Plus, if you see this much of inflammation, it's very, very unlikely to be LPP.
Okay, that makes sense.
Okay. So, and you see if this is involved hair follicle, you're seeing the nice vacuolar alteration with the necrotics, which you can also see in LPP. But it's in LPP, it's the perifollicular fibrosis, which is very prominent. The overlying epidermis entirely is involved. In your LPP, only the follicular infundibular portion will be involved. And again, with this degree of inflammation, like you'll have to prove it to me that this is not LPP. This is not lupus. This is very classic for lupus. Okay.
Okay, that makes sense. Thank you.
Let's go to the next one, which is 19th. Oh, this should be an easy one. What is this?
Psoriasis.
Is this a hairy
Oh,
palm?
wait.
Mhm. Yep.
Lichen simplex chronica.
Or prurigo. You see the nice, this is a beautiful flu. You see that? The
Mhm.
hypertrophied follicular infundibular units with the stretched out vessels and the vertically oriented fibers. And just for your recognition, this is what I was saying. These are bacteria. See how they clump together? So these are bacteria. So this lesion is secondarily impetiginized, but you're not going to mention that. You're going to call it a prurigo or LSC. Okay?
Quick question. Is that like a subepidermal split, like underneath that hair follicle on the left?
Oh, this?
No, on the left.
Oh, this.
Right there. Is that a real split or no?
No, it's actually like a big vessel. Or maybe
Oh,
just
gotcha.
place in the stroma. So you see there is the basal layer is hasn't complete attached, like there's stroma around it.
Got it. Cool. Thanks.
So this is prurigo or LSC. Good. And we have the next one, which is your slide number 20. Okay. Happening in here. What is that?
DM.
Yep. This has got like the most perfect thickening of the basement membrane with very sparse inflammation. It actually looked like almost like normal on low power, except that it has this perifollicular inflammation, beautiful thickening of the basement membrane. Like this is like textbook thickening of the basement membrane. So this would be a connective tissue disease. And yes, so this, I believe this was from a patient with DM or SLE because they typically tend to be more posse inflammatory. You have the 21, which should be simple. What is this?
Subacute contact dermatitis.
Or like it's on acral skin, right?
Oh yeah. So
Dyshidrosis or Pomphylix.
mm,
Okay, good. We have the next one, which is 22. Okay, this is, it looks really dark. I'm going to help you guys with this. So what do you see in here in low power? Do you want to go up on this?
no.
So there is lichenoid inflammation, which there's perifollicular inflammation, perivascular inflammation, and there is some split in the epi, right?
Mm-hmm.
So multiple things. And what do you see? What is that?
Wait, what were those three things you just said? Like,
Yes, so on low power, this has lichenoid inflammation, perifollicular inflammation, perivascular inflammation, and a split in the epi.
I mean, it sounds like lichen striatus, but not like the split in the epi.
Okay, so okay, fine. If you thought about lichen striatus, you would still have to go up higher on this, right? Like, what is that? And what is that?
Is it
Viral
pleva?
infection.
What is that?
Viral infection. So it looks like you've got margination and molding.
Yeah, you can see the beautiful herpes cytopathic chain. You can see the multinucleation molding and the margination of chromatin. So this is herpes infection. These are all infected cells. So a blistering disease which looks really busy, you should always think about herpes infection. If the blister is not falling into one specific category and you're just being annoyed by the background noise that is happening, that likely is a herpes infection.
Can you point out like the 3 viral cytopathic things that we
Yes.
always talk about?
Yes. So it's actually filled entirely within this. This is just very dark, thick sections. You're not able to see it. So I'm going to point out here. So you look at this cell and look at this cell, this cell. So let's take, for example, this cell. So 1, 2, 3, 4. That's 4 nuclei stuck together. That's multinucleation. Then you have molding, because you see how beautifully they are molding to one another. That's molding. And margination of chromatin, because if you look at, this is your normal chromatin pattern. You can see a nucleolus and you see the chromatin, which has kind of like a granularity to it. But if you look at this, this looks like a glass. You see that? Because the viral particles have filled up this nucleus and it's pushed up the chromatin. So it looks like a glass. So that's margination of chromatin. So it's all clumped towards the periphery. So that's what you mean by the 3 M's.
Mm-hmm.
The
Gotcha.
perifollicular inflammation, is that also typical of herpes?
Very, very, very typical. Typical to the power of infinity. In fact, when I see perifollicular inflammation, sometimes that may be the only clue. If you see follicular inflammation or destruction of the hair follicles called follicular epithelial necrosis with follicular inflammation, no other entity except herpes can do that.
Got it. Thank you.
Yeah. Superficial deep inflammation, perifollicular inflammation, acantholysis is very common. So on low power, sometimes it can even look like Grover's disease to you, because the cells are falling apart and they are dying. So you may think it's a acantholytic dyskeratosis, but it isn't. So what I'm trying to say is, if it looks like a really blizzy slide with a blistering process, think about herpes. Okay. So we'll do probably till 25, and then we will resume in the next class. So what is this 23? This should be simple. So what is happening in here?
So
So warty D.
Is it a warty D?
Probably.
It's a tiny, tiny papule. There's one papule here, there's another papule here. You recognize the disease process, because what is the disease process?
Dyskeratotic acantholysis.
Yep, acantholytic dyskeratosis. You're seeing beautiful corons in here with core grain. So that is, but it's a tiny papule. You see one here, one here. So what would that be?
Grover's.
Grover's disease. A warty D is a single big papule. This is the 24. Okay, this we went through. So what is the predominant finding in this biopsy?
Chronic interface or lichenoid?
Lichenoid. It's lichenoid. You see the band of inflammation?
Mm-hmm.
Right? And then there is a blister here. So this is
Bullous LP?
yeah, this is bullous LP, and adjacent to it, you can see that the cytoid body is here, and that's producing your subepidermal vesiculation, which is your max dose of space. This is bullous LP. So see, the low power is so beautiful. Everybody recognizes the lichenoid infiltrate at low power,
Mm-hmm.
and then you see the blister. So the base of the blister in bullous LP will have that lichenoid inflammation and also adjacent to it.
I think like the bubbles in the basal layer like really throw me off. Can I like go down the interface differential?
You didn't go down, you said?
No, I said I do go down the interface differential when like not in this slide because this is obviously a blister, but like to the periphery of the blister, there's like all the bubbles in the basal layer, and I start to go down the wrong differential.
Yes, but lichenoid, remember, is interface. So you will see the bubbles, but the predominant finding of calling something lichenoid is the band of infiltrate. And you see how the deeper portion of the dermis lacks any inflammation, which is another feature of a lichenoid as compared to a lupus-like or a connective tissue disease-like process, because it is concentrated around the vessels as well, the inflammation.
Oh, that makes sense. Yeah.
Okay. And then we will do the next one, which is 25. Okay, what is this?
Is this Haley again?
This is what?
Is this Haley again? Is that like a dilapidated brick wall? No, it's not. Because now I'm seeing cytokeratin granules.
Yes.
So is this EHK?
This is EHK, yeah. EHK, if you're not thinking about it, you will go down a rabbit hole because you will think about, oh, is this a what? Is this EDV? Is this psoriasiform, necrolytic entity, nutritional deficiency? So you have to, whenever I see EHK, in my mind, I'm revising all the pathogenesis. Okay, fine. Am I really seeing what I'm seeing? I'm seeing hyperkeratosis, I'm seeing hypergranulosis, I'm seeing acanthosis. Correct. Check. That happens. Then I'm seeing pallor of the stratum spinosum. And why am I seeing pallor? I'm seeing pallor because of cytoplasmic dissolution of keratin filaments. So for that reason, I have to see clumped keratin granules, pink inclusions, which I'm seeing. Then it is EHK. You always have to explain the pathophysiology to you in your mind to be 100% sure you're dealing with EHK, because it can be a confusing reaction pattern. All those things are always present in EHK: acanthosis, hyperkeratosis, hypergranulosis with prominent chlorohyalin granules, pallor of the stratum spinosum, and then cytoplasmic dissolution, producing the pallor and the clumped pink inclusions.
So if this isn't acantholysis, then you should be able to see like the desmosomal appendages between the cells, right?
Yes, so acantholysis is, let's go back, which was a slide of Haley disease?
15.
So in this particular slide, you see how predominant this pattern is. So the pemphigus pattern actually points towards a Haley disease process, because you see the nice suprabasal splitting.
Mm-hmm.
And then this is never going to be the predominant feature in Haley disease. This feature is something you will have to look for. If this is the only part of the slide I had, yes, it would be challenging to distinguish from EHK. But unfortunately, or fortunately enough, that's never the predominant finding in Haley. The predominant finding in Haley is the blister, which looks like pemphigus vulgaris. And you have to go and find this. Okay?
Mm-hmm.
Okay, so we're going to end here. I want you guys to go back and I want you to revise these slides. Trust me, they are pathognomic for every entity we have gone through. So if you have had trouble recognizing it, before we go on into granulomatous diseases, I want you to seal the deal on papillosquamous diseases and blistering diseases. So please go back and revise them. Okay?
Awesome. Thank you so much.
Thank you. You have a good day, rest of the evening.
You too.
Thank you.
You too. Thank you.
Thank you. Bye.
Bye.